antipsychotics, or for that matter, the Parkinson's, disease, or ALS, or MND, motor neuron disease, right? The long-term impact is on their cognition, and that impacts their overall quality of life. And everybody understands, oh, they're emotionally overwhelmed. Of course, they're emotionally overwhelmed. The caregivers are too, for sure. But it's not emotions that is impacting them. It's all about cognition, their awareness of the surroundings, of the environment, their reactivity, right? So this is a cognitive rehabilitation program that I've developed, and it started functioning since early 2022. And so it can be done in both the modes, online and in person, with detailed assessments, evaluation. And yes, but I prefer people to come to a physical space, because there they will be having a lot of gadgets, lot of equipments, lot of manual tasks and everything, right? So now, what is cognitive health? As I mentioned, before we explore how to remap and orchestrate, we must understand the system itself. So the fundamental question is, what is cognitive health? It's the in the very simple language by APA, American Psychological Association, cognition is the mental process of acquiring knowledge and understanding, just the comprehension, understanding, and knowledge. It's the entire set of core of brain functions. Here I'm talking about functionality of brain. I'm not focusing on the structure of brain here. We used to think, to learn, and to remember, right? So now, if cognition is the process, then what is cognitive health? Cognitive health is the foundation for robust cognition. So if you're cognitively healthy, that means you're in the state of optimal brain function across all the cognitive domains. Optimal, please mark my word. I am not claiming again here that you will have high memory, I mean, very good improvisation in the memory or something. Optimal memory for you at that particular age, life stage, or current situation, depending on what medications you are on, right? Situations and all. So optimal, optimizing it. For sure, you won't be high or you won't be low. You will be under optimal performance. What is required, right? So you can think of it as, peak operating conditioning of your brain's command centers. And a cognitively healthy brain actually is not just free from the impairment, it's actively effective. So how it can be effective? People, because it can, reliably and efficiently do the work of daily life, ADLs, activities of daily living, right? ADLs and growth. So, specifically, it can learn new things, remember what is important, solve problems efficiently, not in a panic mode, because they understand the hallmark of anxiety is panic and overthinking, worry, overthinking, and panic. Then maintain focus and attention, which is very much required for all of us, specifically in this age where a new disease called as digital dementia has been emerging, right? So, I mean, I'm not a very big proponent of a digital word and, all those things, because anyways, it's getting obsolete. When I used to write to an email to my mentors initially. Oh, I used to think flowery words and, really lot of work for my brain to impress them, right? Now, write an email to chat GPT, Perplexity, Copilot, anything, and the draft is there, copy paste, and it's in. So what are you doing to your brains? The most basic function for the brain, which is meant for cognition, you're even stealing that from your poor brain. And that's why I'm sorry, but that's my perspective. But yes, the cognitive program is an amalgamation of both your digital, because in some contexts, AI driven or digital driven algorithms works because if I want you to quantify something, you need to have a precise measurement to show it's digital, right? But yes, why manual? Your manual involvement is important because all your senses and sense organs are only involved when you are doing certain manual tasks. If I ask you, okay, just wear this headgear and, for example, neurofeedback training, wear this headgear and do this training for, it will happen. Functional neuroplastic changes will happen after 30 sessions or something like that. Nothing will come immediate, right? It will happen, no doubt about it. But it won't be long lasting because it's functional. Here, you are not an active participant. You are just a passive recipient of what is happening. But when I talk and when I say you do certain manual things wearing the brain gears, fine, because I am getting a real time results, but you are doing that task. And your senses are involved. All five senses are involved. Your visual, auditory, kinesthetic, motor, touch, tactile, everything. So you are the participant in this. That induces conscious neuroplasticity. This is called as conscious neuroplasticity, that you're aware and you're an active participant, right? So mental health is a state of well-being that encompasses our emotional, stress, sadness, anger, and happiness, psychological issues like self-esteem, resilience, and outlook on life, and social domain, building and maintaining healthy relationships and well-being. So that's the difference between cognitive health and mental health. And we'd already discussed. Now, the philosophy of our program is inspired by the philosophy of René Descartes, cogito ergo sum, I think, therefore I exist. I think, therefore I am. Right? So that's the foundation of this program. So built on two core principles derived from philosophy and modern neuroscience, that the conscious self is malleable through directed neuroplasticity, where you yourself is an active participant, just not a passive recipient. Then enhanced cognitive control is the foundation of an empowered existence. As I mentioned, it's just not about thinking. Cognition is all about your awareness around you, right? And that awareness includes your emotional health. That awareness includes your relationships. That awareness includes your peak performance. That awareness includes your physical health, everything. So targeted cognitive training directly strengthens the I think, leading to a more, resilient and adaptable I am. And the conscious self can be reshaped through the deliberate regulation of thoughts and emotions. Now, when we talk about this, we know limbic system, we know prefrontal cortex, we know basal ganglia, right? Everybody, we know temporal lobe, hippocampus, I mean part of limbic system itself. So, but then, what we have attributed all emotions and fears to amygdala or limbic system, right? And the consciousness, the way of thinking, reasoning, logical things, okay, prefrontal cortex. It is indeed. It is. But do you really think are they working in coherence or in connection, or they're working separately and isolated? No. Right? So if you're able to comprehend, understand, and think clearly, you will take the decision and you take your responsibility that, yeah, this decision is taken, whatever happens, I am wholly solely responsible. So then you will not get emotionally overwhelmed, even if it goes wrong. So what I'm trying to tell you here is everything works in coherence and connectivity, right? So, so from cogito to cognitum, the next evolution of, I think, the cognitum program, it's a very holistic neuroscientific evidence-based protocol, and it targets for all domains. When we do the assessments, we have different assessments. So we target 5 domains. We do the detailed cognitive profiling. We do your emotional health, your mental health, which includes your psychological health and everything. We do the spirituality index as well, because that builds resilience, both cognitive and emotional resilience. And whichever faith and religion you are, it's just about you being a spiritual person. Second, we take into consideration the social domains. And then the most important part, hemispheric dominance and your personality trait assessment, right? So the assessment is very holistic, as I mentioned, because it's just not about pinpointing one certain region and area of the brain. It's about you, right? You as a human. So the cognitive paradigm, rewriting the code of thought, a multimodal experiential approach to cognitive training and rehab. Now, when I speak about cognitive training, it is for you, me, anybody who is not under any kind of medication. Any kind of medication is a wrong term, sorry. Any psychotics, antipsychotics, antideps, anxiolytics, or any neurological chronic medications. Rehab is for them. And it takes time. Then targeted and personalized protocols, integrating top-down and bottom-up processing, building durable cognitive schemas. So The core idea was by actively remapping maladaptive neural circuits via targeted neuroplasticity, we do brain mapping, quantitative EEG, pinpointing the regions of coherence, hyperconnectivity, phase coherence, and everything. And we design a targeted protocol. Now, somebody comes to me and asks that I'm suffering from anxiety, chronic anxiety. There's a first, my first case for this program was an anxiety patient. He was 38 years old here in Dubai. And severe anxiety since grade 8. When he approached me, he was 38. And he was having SNRIs, 225 mg BD, right, daily. And when he came to me, he was literally crying. GAD, it was GAD plus panic attack. And he was actually progressing. It was comorbid with depression because of the prolonged intake of the medications. And but the very good thing about that guy was that he was pretty much motivated to get rid of the medications because he couldn't sleep if he doesn't pop the pill, right? And his performance and his decision making skills and his behavior, everything was getting impacted. So this guy, he was really motivated. So this guy was the first case that I had actually cured with this approach. And within 6 months, he was out of his chronic medication, which he had been taking from 20 to past 22 years. And till now, he is not on any medication. Yes, there is sometimes some relapses and sometimes it happens because it's behavioral. It happens. But then he understands how to manage it without popping up a big pill and, again getting into the cycle of insomnia and all that stuff. So I'm not claiming that if you take this program, so you'll be cured for all. Nobody can claim that. This is life. Things changes, behavior changes, pattern changes. Things will happen. But what if you are the master of your own conscious neuroplasticity? Right? So the theoretical underpinnings is first and foremost is leveraging neuroplasticity. And we all know the Hebbian's principle, neurons that fire together, wire together. Right? We all have read it in schools, maybe. Biology, harnessing Hebbian's learning, right? And then the principle of use it or lose it from potential to actualization. And we address the problem, the stuck neural pathways, the limiting thought pattern, the limiting belief system that we do after extensive assessment, evaluation, brain mapping, and everything, right? And the solution, that is a complete software, a functional software update of your brain, right? And the treatment, which is self-directed neuroplasticity, making you the master of your own fate. Now coming to the program, though, so this is actually, I just wanted to brief you all about how our programs, if somebody comes to the wellness clinic and he wants to take something, some programs, some modalities. So of course, everything is, first of all, you have to have a consultation with your own client information sheet and all that stuff. We have a CRM online a portal where you can put your details, you will get a login ID and everything. And then you'll put your information. After that, you will have 3 modes of assessment, 3 stages, which is one is your questionnaire-based assessments. Second is your digital assessments, which will map your cognitive profile. And third is face-to-face virtual. And plus additionally QEG brain mapping because it has an additional cost and you need to be physically present in the clinic for that. All right. So then what is the rotation logic? The rotation model here, suppose, this is just one of the pictures. It's just not that it is based on these 3 modalities. So one is suppose a neuromusic therapy, which we gave under cognitive neurosthetics training, CNAT, which encompasses neuro art and neuromusic. Why music? Movement, coordination, balance. It includes your finger gymnastics as well. It includes your overall leg, arm, hand movement as well. Basal ganglia, cerebellum, movement coordination. Now, next is station C, which is station B, which is neuro art creation studio. It's just not about creating a piece of art or doodling on paper or something like that. It is extremely, extremely scientific. The protocols, we have sheets for the workshop here. If anybody would like to do that thing, they can do and they can have a look. Second is cognitive task arena, which has both manual as well as digital. Digital for the cognitive profiling, as I said, I get a real-time data, I get a graph, I get a quantified score, right? Manual because I want you to involve all your five senses and sense organs to induce rapid neuroplasticity and not to be a victim of AI. So, like that, you are at least you're giving some fuel to your senses and sense organs, right? Uh, so, how is a standard station protocol runs? There's a theory, there is a demonstration, there is a hands-on training, and of course, reflection. For manual tasks, there's a scoring sheet that everybody has to fill, and we are always there to guide. And for digital, of course, there is an automated software algorithm that then pre-activity, we need to take your snapshot of your cognitive profile for cognitive domains. Okay. So all 21 to 32 cognitive functions are addressed with this, the digital testing. That's completely digital. And there is a questionnaire and all, but that's on the stage of assessment itself, formative questionnaire. But this is digital. For the patients, of course, you have slums, you have MOCA, you have MMSC, you have Cognistat for, dementia, Parkinson's and all that stuff. So that's different. That's different. But here, for the patients, but anybody who comes to me, he has to take this cognitive profiling test. And then I've just jotted down certain, they're all neuropsychological tests or based all neuropsychological assessment, based on neuropsychological assessment battery. Neuropsychology means I'm talking about cognition. I'm not talking about psychology, mental health here. Neuropsychologists deal only with the cognitive part, right? So trail, making digital emotional face, and there are different types of modalities, but all are neuropsychological based on the neuropsychological assessment battery. And then this way there is a cognitive profile that comes, right? Okay. It's a very detailed report. I just put two snips of it, but it's a complete detailed report for your all 21 to 29 cognitive functions. And then now, suppose if I recommend neuromusic therapy to you. Why? Because of your assessments, evaluation, and everything. I understand not only on the basis of cognitive profile, but your emotional overwhelm, your psychological profile, your social profile, your spiritual, everything. So I think, oh, this is the protocol that will help her most. So I will guide you to this station, right? So now we can see the changing drumming tempo immediately shift frontal lobe activity from resting state to engaged focus. So it's just not having beating on the drums. There is a certain code or a protocol that is given. The drum has been divided into certain areas. Okay. And I just want to tell you the intricacies of the program that if I assess you and I found you over emotional and sad and under depression, that you're just about to cry, right? Then I will never ever guide you to a neuromusic station where there is a melodious sound. I will guide you to drums through Congo bongos, right? Because your personality has to be, you cannot, there is something which is biology, but there is something which is your personality, your behavior, right? So we need to address both, right? So, of course, that will take you immediately from the overwhelm of theta to beta or gamma, right? So I want to give that sound. I don't want you to sink in melody again and go into the deep sleep. You're already sinking on theta when you're under depression, right? So then every section is divided into certain parts, the brain regions, because I deal with the brain. So my each and every therapy, everything is brain or neuroendocrine axis, your hormonal axis. So it's divided, then we will give you a code, right? Then we will give you a code. You have to tap, either it's unilateral or bilateral or involving contralateral sides or forelimbs and hind limbs, your hands and legs both, or which finger, whichever. And there is a code that you have to tap the section, right? So in that way, you are cognitively engaged while doing that task and creating a rhythm. And you're always wearing a headgear or headband where we can see your real-time pattern. And there are some musical softwares also. They will also tell what the rhythm pattern and all that stuff. So, so this was the thing. The theoretical foundations: neural entrainment, rhythmic auditory stimulation synchronizes neural oscillations, creating a temporal framework that facilitates motor planning and execution. Network activation: music engages distributed networks simultaneously, auditory, motor, limbic, bypassing damaged pathways to assess memory systems. And attention, of course, attention and focus is trained. Tempo and meter directly influence arousal levels, allowing precise titration of attentional focus and cognitive load. And I also want to tell you, we also do the brain and wave entrainment, which means we ask you a song, your favorite song. We superimpose that song on certain softwares based on your current status of your brain map, the coherence and hypocoherence and the brain waves. And then we superimpose that song and the frequency of that particular brain wave. And then we ask you to listen and give you certain questions. While listening to the song, you are supposed to, for example, count the word happiness in that song, how many times you play. For example, just so when you're listening to the song, you're also cognitively engaged. You're enjoying. The song is already superimposed the pattern of brain wave I want to entrain on you. Right? So everything is accompanied by a cognitive task here. Now, we are again, if you say neuromusic therapy, so we have active, which is called as an attention orchestra. Again, you have drums, focus attention mode, which will help you. Participant must sustain a precise rhythmic pattern for 3 minutes without deviation and with certain codes. Then divided attention mode, which is cognitive load, because your attention is, I want to divide your attention because attention is sustained attention, focus, divided attention, alternative attention, and all that stuff. So if your score comes, divided attention is like multitasking, divided attention. It's not good. Your score says, and you want to get in train for that. I have to design a task for you and prescribe that task to you, right? So then maintain the base rhythm with hands while verbally counting backwards. I mean, this is just one example that I'm telling while you're doing that. Because it will be accompanied by a cognitive load, a cognitive fatigue. So that creates cognitive fatigue and tasks and divide your attention. So this time, alternate. And then switching mode, which is cognitive flexibility. So auditory cue like whistling, and participant must instantly swap beat patterns or instruments. This trains set shifting and impulse control, cognitive flexibility, your reactivity, emotional reactivity. So we have in our neuromusic station different EEG headsets, and all the music station is full of different instruments. So then memory melodies, again, it's a melodic recall. Listen to an 8-note sequence, then recreate it on the either virtual keypad, or we have xylophones, right? The dual task rhythms, recreate melody with dominant hand while tapping a specific rhythm with the non-dominant hand, or using altogether a different instrument with a non-dominant hand, right? Then semantic encoding, encode a list of 5 abstract words into a unique melody for later recall. Then if I go to the neuro art creation, you can visualize neural change, non-verbal processing, emotion cognition link, spatial reasoning. So it's all about, when we talk about non-verbal processing, it bypasses damaged language centers like Broca's or Wernicke's. Like some people, have you ever encountered, like there was a case of ADHD and 2 cases, ADHD and one autistic child. The mother came, she was undergoing speech therapy for long. Right? Now just think logically about it. This for 5 years, she had been going to a speech therapist because she was seeing that her child was not able to speak. He was not participating in the conversation, and he just wanted to be socially secluded like that. She thought, and everyone has told that he is suffering from with the assessments and all this issue. She thought that it's all about speech therapy. The recommendation was speech therapy, right? 5 years of speech therapy. The child couldn't speak. Right? Somehow she saw, because our program, you can go to the website, through LinkedIn, through Instagram. Somehow she came to know about this program. She came to me, she got her child evaluated. I told her there is no issue with the Broca's, there is no issue with the articulation. It's speech production. And you're giving a therapy for speech. It's just that the child cannot speak. It's not about the networking in the Broca's in this case. It's about the psychosocial and neuropsychological domains that needs to be targeted for this child. Right? I think 4.5 or 5 months around. Initial brain map and the 6 months brain map. I am not claiming immediately happened. Right? It took some time. And these novel protocols really attracted child. We have different for ADHD and autism also we have different protocols for kids as well, which are very novel and they just like it. So slowly he started speaking over a span of 4.5 months. And his social bonding, everything was really good when he was going home alone. And we were prescribing certain protocols to the mother as well. Like a dietitian prescribes you that you have to do this much. So I told the parental involvement is important. You can take this therapy for 2 years. If you have money, no problem. You're most welcome. I will make money with that. But the thing is, until you're not involved, your emotional involvement and your support is not there. That's what all domains needs to be actually addressed. So it was not about the speech therapy. The problem was not in the Broca's area of speech articulation. Right? So this is neuro art, nonverbal, emotional cognition link, and spatial. You have this case study. You can see that. I think it's very, you can see emerging coherence in that. Then there was severe spatial neglect. Then emerging coherence. The image is not here, but and then spatial integration, full canvas utilization. Full canvas. It wasn't a very beautiful piece, but for these kind of patients, it was an improvement. And then, so what activities we do? Emotional palette mapping. We have different things like color wheels for linking affect to hue spectrums, emotional cards, prompt deck for state identification. We have emotional card or the taglines. We put it and we say whichever is you think is gelling most with the current situation and which you want to be, what you want to be. So then abstract canvas, large format paper or digital pad, even digital pads, because some people, they don't want to mess up with the colors and all. So it's okay, fine for them. Then identify state, then match colors, express, transform. The cognitive and neural targets are emotional regulation. Of course, art therapy is emotional regulation. Goal directed because they went out. Then there's something called as neurographica. There is an art practice, neurographica. So in that, they just, scribble something, wavy, circle, roundish patterns, and then we ask them it's a well-established protocol. Then we ask them to round off the edges, right? And when they round off the edges, we ask them to color them differently. So their state of mind at that particular point of time, it reflects the way they color, right? And once the piece is colored and the round off and then they are all bold and it's a beautiful art piece that you can hang in the drawing room, worth maybe 2,000 dirhams, right? But what is happening at the background? Emotional regulation, goal-directed behavior, visual spatial processing, we are targeting. We have different art therapy protocols. And some of them are always accompanied by a cognitive load, a cognitive task. It's just not painting and coloring. We have sheets there, you can have a look. Then another one for Neuro Art Creation Studio, connectome sculpture. Like pipe cleaners, nodes, the straws and the pipes, right? Or the pipe cleaners. So you can have nodes and brain regions. I mean, you say that you can see this diagram, the way it is. So strong, you can tell the front, there is a canvas or there is a chart, a picture. We say this is frontal lobe, this is this. I know what is it. FL, I write it, but for the patients, I tell them, or the clients, I tell them, this is responsible for your decision making. This is responsible for your fear. This is responsible for you. But there is a coding on that FL or limbic LS or amygdala AM or something like that. And then we put some, toys like this guy on those notes. And then we give these type of things, beads, new desired connections, colored strings for the neural pathway. We tell them this is your brain. This particular guy is controlling this. This particular guy is controlling this. So how do you want to actually coherently built a system in your brain. This is your brain and your guys. How do you want to build a coherently a very optimal functioning system? Where I'm not asking you to get rid of fear because fear is important. I'm not asking you to be in the fear zone all the time because that is bad. So then they do something and they create something and then explain something, right? So that's their brains. This is the connectome protocol. And then again, the third arena is cognitive task, which is gamified brain training like this, right? And manual task, of course. So manual task, they have to sit and they have a scoring sheet and they. So adaptive difficulty, dual task science and real world transfer, you can see there. This is a supermarket situation. We give them the situation which targets their specific cognitive function and emotional overwhelm. And then we have planning station, activity one, if you executive functions, for example, obstacle or problem solving. So it could be hybrid, physical and digital challenge. I can give you both. So it's like planning station arranged physical puzzle pieces to match a complex digital blueprint, visual, spatial, and sequencing. But those puzzles again are not simple puzzles that you are just putting the pieces. It's different, accompanied by a cognitive task. Then working memory maze you have, and flexibility hub and inhibition station. This is for your cognitive impulse control, your reactivity, basically, just emotional control, impulse control. So we have different things, and you can see activity two, VR kitchen safety challenge. So commands are coming. They're sitting at the station, they're playing, right? And they have to, like, patients enter a, high fidelity visual kitchen. Their primary task is to prepare a multi-step meal following specific sequencing rule while managing environmental inputs. For example, if somebody is cooking something, there's a task given that you need to prepare this, and then suddenly a mom is in the kitchen and the child comes and say, I need this, I want to go and play, and then suddenly your phone beeps and all those are the distractors, basically, right? So it's a gamified kind of a thing, but what we are actually training here is something else, right? So we have both take-home toolkit and implementation pathways. So essential resources to start implementing cognitome principles immediately, which is neuromusic prescription card, neuro art starter kit, cognitive task, digital and manual both, featuring adaptive difficulty and protocol templates, of course. And strategic roadmaps for integrating the framework into your practices, like clinical integration, training modules, equipment procurement guides, home-based programs, which we give instructions to the caregivers, specifically with the people with dementia and severe tremors and Parkinson's case. And research collabs, of course, we are always open for that. And the key takeaways, what makes this about cognitive program or this workshop transformative? Basically, this is personalization over protocols. Your protocol is only based on your cognitive profile, emotional profile, social profile, spiritual profile, personality assessment. So the protocol that I'm giving to you is not same for the next person who is sitting. In fact, for that matter, a person who is having anxiety, people come to me, anxiety score on anxiety is there, but anxiety itself is of 13 types. Now that anxiety is a presentation of your personal upbringing, your geography, your culture, your knowledge, your financial status, your relationship status, and everything. So even if you are suffering from GAD, I mean generalized anxiety disorder, and your best friend is also suffering from the same, but the protocols will be different because based on your profile, right? That's why it works. Normally, we give the same prescription to everybody, right? And we are actually overlooking multiple domains that needs to be, assessed or evaluated at least. Now, why I am saying this? Because I have a multi-domain uh, academic background, basically qualifications. So, biomedical sciences, then PhD in neurosciences, then neuropsychology and clinical psychology, and then fMRI, and then quantitative EEG and neurofeedback. So I integrated all those things, all these degrees, these diplomas, my postdoc, and all experience, and created this program. That's why I always use the term holistic, integrative, and neuroscientific. So, as I said, multimodal, multiplied impact, real-time feedback, collaborative cognition, evidence-based creativity. It is the only program that actually makes you creative. Rest, all of the things are either addressing your emotional challenges. Why don't these talk therapies work? Take a therapy, go to a psychologist, 50 sessions, what is happening? You are just still doing your fear ladder or anxiety ladder. I am here today, I am here down. Right? Because it's all about just wending up. It's not about conscious neuroplastic change that you want to induce, you want to understand. You're not targeting cognitive functions and cognitive abilities here. You are just telling what is happening to you to somebody else. And with their limited knowledge or scope of work, they are suggesting what the best they can to you. But why it's not working? Because you're not an active participant for that. You're not working on a conscious neuroplasticity. I'm not saying structural, but at least functional, which targets your neuroendocrine axis, HPA axis, which is very important for every regulation. So the cognitive advantage, a scalable, personalized alternative. It's active, it's not passive, as I discussed. It's precise, it's not generic, because it targets precisely those regions, areas of, or the cognitive domains or the emotional domains that needs to be targeted for you. Right? Then it's holistic, it's not isolated. I am not keeping mental health at bay in this case. I'm not keeping social domain or spiritual domain. Everything is included because you as a person are a personality, right? You're a personality to me, right? You're not a person, you're a personality. Your personality is made up of all these factors: your cognition, your emotions, your social skills, your spiritual skills, everything. We know about personality disorders, right? Yeah. And then it's sustainable, not short term. And I always say the future is experiential. By leveraging experiential tech, because you experience it, and multisensory learning, we can proactively remap the brain for lasting cognitive and emotional well-being, right? So these are the, you can have a look later on. These are certain tasks which are manual, because I couldn't get my all the equipments here to place, right? But these are the manual tasks. So you can see the images and the protocols that are written here on those sheets are very, very different. The diagrams and pictures are very different. Some things are stereoscopic, something is something different, something like that. So then there is these kind of tong pans, tong drums, and there is certain, it's bilateral, unilateral, and there are certain codes. We have marked them, and we give certain codes to how to do it. So this is, I just have actually I just brought them up because I just wanted to show you how it works if it's manual. Because digital everybody can do and can see, and with gears and all, right, with the pictures. And so I always say the brain you train is the mind you sustain, right? Brain and mind are two different things. Brain is brain, a structure, a hardware, and mind is software. It's abstract, right? So the brain you train is the mind you sustain. Clarity of thoughts leads to a calmer mind, as mental health and cognitive health goes hand in hand. And this is our contact address, Tranquil Wellness Tower, JVT Dubai. We are based there, and you can always come and contact. Thank you.
Thank you, Dr. Moita. I think it was a fantastic presentation. Honestly, I think it's the most complete program, rehabilitation program that I've seen. And honestly, we need you in Portugal. Or someone like you, because that's amazing. And I think would change a lot also how the way we perceive and also rehabilitate our patients and everyone. So now I would like to come forward to receive your certificate and photo. So there are here, this one. And Also for the just presentations, for sharing these sessions.
Thank you.
Thank you for your really oh yeah. I think Portugal. We need
No. I was listening to this great presentation and wondering about the beginning of the century, not the 21st century, but the 20th century, when a Portuguese was known for being the beginner, let's say, unfortunate beginner of psychosurgery, and whatever could have been done with those patients, if we had the knowledge that you now know, because unfortunately the prefrontal leucotomy, known as lobotomy, was invented by, created by, not alone, of course, but someone that was a great scientist, and to him we owe the discovery of the angiogram. But we would need now you back in time, if you can, to do the difference, and because psychosurgery probably is going to continue, but in a different way. And I think this is all fascinating and very, very worthwhile. Yeah, thank you very much.
Thank you.
Anyone else like to ask or make a comment?
These are some of the reports that is not used. So you can see we have the stereoscopic brain aesthetics with certain things. Because instruction was given.
There are some questions as well.
All good. I just want to say, I need you to come to Australia as well.
Oh,
And
A world tour.
okay, I just shout. I'm a mental health clinician that's specialized in complex PTSD and personality disorder and dissociative disorder. So it's interesting to get your presentations because there's a lot of things that you've included in here already in practicing in mental health. Yeah. And especially in complex trauma treatment. We combine art therapy, music therapy, dance movement, and also cognitive texting tasks. Yeah, and it's amazing that you have this program that you can capture the outcomes through the quantitative data, rather than just qualitative data, and clinical assessment, like clinical observations. So we need to attention.
please. And we can always even online I can do that.
This
is microphone is on.
Hi, I'm Dr. Adel Orban. I'm a general physician and neuroscience research assistant. I want to thank you for this great presentation. That was so fantastic. And also in our country, recently have conducted and performed this program as a clinical art therapy clinic. And I can say that it has improved the quality of life patients a lot. Because as you know, in and specifically at first we focus on epileptic patients, and it improves their life a lot. And so thank you for your presentation.
Thank you so much.
Anyone else? I just have one final question. So clearly you studied, I mean, you have a lot of PhD, you did a lot of, I mean, years and years of work, but how come you have this idea? Was anything that motivated or to inspire you to take this program?
Yeah, because post-COVID, then COVID was there actually, not post-COVID. everywhere in the news, newspapers, when you switch on the TV channel, you find that people are dying, their caregivers, their family members are grieving. Everybody was in a state of fear and shock, basically. And I know that at that point of time on Twitter and Facebook and all that social media platforms, most of the mental health professionals were trying to pacify them and to consult and to keep aside, keep at bay their anxiety and all that stuff. But nothing was happening. So some of the people even contacted me as well. So there's a now we took so many sessions of this counseling and this and this and this is not happening. And I also tried to console them, convince them with my own limited knowledge and understanding at that point of time. But then I thought there's something which needs to be targeted. It's just not about their venting out their grief and me listening to them and loading them with the words of toxic positivity at times, because toxic positivity is a term, right? Actually, by the way, I just wanted to tell you, write articles. So I used to write articles for Courage Times as a columnist to Brain, Mind, and Health. So there are two articles of mine which is very, very good. One is toxic positivity and gaslighting for mental health perspective. So you can go through that. So then I said, yes, there's something wrong. They're not understanding this. And it's not easy to bombard them with the positive thoughts when somebody is really suffering and grieving. It's very inhuman from my side. I cannot ask people to be okay when they are not okay. Clearly not. And that's why they're coming to you. Right? I said, then what is the thing? How can I change their perspective and make them understand? Then the concept of I'm a neuroscientist. I said, why don't I target their functional neuroplasticity, their cognition, their cognitive abilities, right? To make them understand. Why don't I develop a program in which they are the active participants, not the passive recipients of the information overload or suggestions, right? Then I said, target the cognitive health. To my surprise, I want to tell you that the whole of the Asia, I mean, at least I'm talking about India, where I belong to India and the neighboring countries, that people were not aware about the cognitive health, the concept, because everybody was, using this term synonymously with mental health. If somebody is coming to you, that means he's mentally disturbed or having some emotional anxiety and depression. It happens to me also. I'm also anxious at times because it's life. Keeps on changing for everybody. We are all humans, right? But then how do I manage it? So I said then I started writing a column. I started publishing my e-magazine, which is Cognizine. You can subscribe it via LinkedIn. And you will find immense articles and a lot many podcasts. I mean, still the series is going on. I really tried to create awareness. And then I created this program that target their cognitive health, make them understand, and it's just not about emotions. It's about rational thoughts, logic as well, So then I created this program and it started only after that. And it really, really, really helped people. I'm not claiming that, they are not remembering or they didn't grieve at that time. But yes, they were able to cope up and manage very effectively without sinking for the pills and, and that's how it's done.
Thank you. It even makes it more meaningful.
This sure. Yeah, I don't have time as I should have actually have this. You can read this. So anyway, please, there are pencils if anybody wants to. Different protocols for every card is different, right? So we have, as I mentioned, this card says about the chest quest, and
this card is about the naturometric mind, and this is the absolute geosthetics. This also is absolute geosthetics. And there is one, the stereoscopic one, right? So the activity was there actually. What do you need to do? The instructions were there. After doing those task A and task B, you need to answer these questions. So, I just want them to read the instructions. They can every time there was a question card is there and they can take.
I'm sorry. Sorry. So the air, isn't it?
Yeah.
And it's in the final.
Last two slides. I mean, this one. So you all can.
Why is it not? Yes, no, that is.
Okay. So this is how it needs to be done. Just read the instructions so that you can do it later. AQ is aesthetic quotient. Aesthetic quotient. As per your AQ means your beauty, the way you want to beautify it. In task B, you need to color the image that you didn't choose at first glance. After listening to certain music or appreciating your beauty of your hands or your own stuff. Because this comes under neuroaesthetics. So, and then color or design the leftover image which you chose not to color at first. And then answer questions 3 and 4 mentioned in respective sheets. We have actually not many color pencils, so I think we really would like to do. Yeah, because I always ask 2 colors because of no white in this generation. Anybody would like to do? I can give the play.
After America, because we are running.
No, you can start.
Yes, she'll start and then in the end, we say,
They have written instructions, right?
okay, so now, our next presenter, that's going to present that poster. She about gut-brain axis, interventions in epilepsy. And she's a neuroscience research assistant at Machado University of Medical Science in Iran. So, Dr. Gazale, please.
It's yeah, blocking a bit. I don't know. It's
No.
Presentation purpose, no? I think it's. No, it's a reaction.
Number 14.
Good afternoon. I'm Dr. Ghazale Qorbanijad. I'm a general physician and neuroscience research assistant. And it's an honor to present our research entitled Gut-Brain Axis Intervention in Epilepsy This is a systematic review, and we more focus on diet and gut microbiota modulation. Epilepsy is a global health issue which affects over 50 million people worldwide. Despite many advancements in this research, in this area and about anti-seizure medication, still 1/3 of patients develop to drug-resistant epilepsy. This lack of control shows a lot of comorbidity and leads to lots of comorbidity. As you can see in this figure, that it shows the worldwide and the spread of different regions, that epilepsy shows the year that epileptic patients live with disabilities. And as you can see, it's not related or specific to the country or a continent. It's widespread across different countries and continents. So there is a critical need to looking for novel and attractive therapies for epilepsy, which is also identified and emphasized by World Health Organization. Gut-brain axis intervention or gut-brain axis represent a biodirectional communication between our brain and our gut. As you can see in this figure, this pathway is mediated by vagus nerve, lipid metabolites like short-chain fatty acid and GABA. Also, based on evidences, healthy gut microbiota or healthy gut microflora has some duties like pro-inflammatory and anti-inflammatory. However, in some disorders that I'm going to talk about the epilepsy, this modulation and the normal gut microflora got changed. And these changes is toward to change the seizure frequency, which based on the evidence and based on many systematic reviews and meta-analysis studies, it increased the seizure frequency. So there are some interventions like ketogenic diet and also probiotics that this intervention can change this situation. Based on this, we aim to present and conduct a systematic review research, which we followed PRISMA guideline, and we search across databases, includes PubMed, Web of Science, Schoolbooks, and Cochrane. We more focus on studies from 2050 until 2024. And we evaluated studies which evaluate human trials investigations, and specifically evaluated individual diagnosed with epilepsy or drug-resistant epilepsy, and they underwent ketogenic diet, probiotics, or prebiotic interventions. And this shows clearly that from 97 initial records that we found and searched from the databases, 9 studies includes in our study that met our final eligibility and final criteria. One study was a randomized clinical trial, and the others were observational or cohort study. As you can see in this figure, it's clearly shown as our included study, which 5 studies related to ketogenic diet, 3 studies were related to probiotics, and 1 study specifically evaluated the dietary modulation in epileptic patients in comparison to healthy ones. And besides, we evaluated some other factors like microbiome modulation, inflammatory biomarker, and cognitive effect. Here I'm going to talk about our clinical result, and I categorize them in 3 ways: ketogenic diet, then probiotics, and at finally neuropsychiatric situation. At first, I have to tell you, based on our evidence and included study, it revealed that 7 out of 9 studies show a significant reduction in seizure frequency, in which ketogenic diet showed the most consistent one, and in which most studies in this area even shows a 50% or greater than reduction in seizure frequency. However, we didn't mention about any limitation or our follow-up duration. However, they were so varied. at least one of the studies shows 64% of infants which receive greater than 50% seizure frequency reduction just with 1 week of this intervention. And also the maximum follow-up duration and the maximum intervention duration exactly was 6 months. About probiotics, all included studies show a significant reduction of seizure. However, these findings were mechanistically supported by some changes like significant reduction in inflammatory biomarkers like interleukin-6 and CD40, and also an increase in inhibitor neurotransmitter GABA. And the last result is about the neuropsychiatric condition, which specifically we evaluated cognitive and quality of life situation, in which while cognitive outcomes were inconsistent and didn't show any significant changes, probiotics shows a significant reduction in anxiety and depression score, and also a significant improvement in general quality of life and total well-being of included patients. Moreover, all three categories were related to microbiome modulation, in which 8 out of 9 studies shows changes in our gut microflora, in which was toward increase in beneficial taxa like Bacteroides and Bifidobacterium, and a reduction in pathogenic taxa like Proteobacteria and E. coli. So overall, I want you to all focus on this figure. As we discussed, we can say that ketogenic diet and probiotic intervention could be a potential adjunctive therapies in epileptic patients. And as you can see, I can list you, and there are several changes that happen. At first, these diets like ketogenic or probiotics has some changes in our gut microflora, which is, as we discussed, are toward the increase in beneficial taxa. Also, ketogenic diets produce some ketone bodies like propionate and butyrate, and also increase the short-chain fatty acid in our body, which all are toward the increase in energy and increase the metabolism of our brain. And also, studies have shown that it increased the ATP synthesis, which is an alternative energy for our brain. Besides, about the inflammatory biomarker, we have seen that there is a reduction in inflammatory biomarker like interleukin-6, CD14, and also TNF-alpha. And also, all these factors are related to GABA and increase the GABAergic tone, which can stabilize our neural membrane. So, now, overall, we can say that this intervention in our gut microflora do something just more than change our gut microflora. It induces a neurometabolic shift toward changing in seizure frequency. Also, another thing that we have revealed that in this study that some changes in microbiome or gut microflora could be as a biomarker to predict the responsiveness to the ketogenic diet and some other interventions. And also, besides, I want to mention about the precision medicine or personalized medicine that we hope that in the future we can use as these changes as the something just a supporting factor for the future to support the personalized medicine and using this approach for epileptic patients. However, I must mention about our limitation of our study as you use so that we are lack of enough randomized clinical trial study. Just we had one, and also the included study were small in sample size. However, there were no study that mentioned about the side effect of this kind of an intervention. And I think I personally want to suggest that it have to consider for the future research, because it plays an essential role in the quality of life and total well-being of this kind of patients. Thank you so much. If you have any questions.
Thank you very much, Dr. Gassi. And so, from I think the neurosurgery perspective, we
Yeah.
not only like used to plan the like the surgery, the patient, just
Yeah.
thinking about the surgical act, and we forget sometimes of these, I think, side
Recovery
effects
or the
that
recovery.
actually, to be fair, I learned today. So
Thank you so much.
So anybody else has any questions? Or would like to comment? Okay, so we all know that we have to do ketogenic diet. Instagram advertisements and so on are true, so let's go. So now please come forward, receive your certificate and take a photo. Okay, thank you.
Thank you.
Okay, so now I would like to call Dr. Chaitra Shashi. Am I saying pronounced correctly? No. Okay. That is going, she's a junior resident in the Department of Internal Medicine and of a college of, what's it called?
Yeah, in
Okay.
India, yeah.
Very good. And she's going to speak about simultaneous presentation of FAR syndrome and cervical ossification of the posterior longitudinal ligaments. Thank you.
Esteemed dignitaries and faculties, a warm good afternoon to one and all. I'm Dr. Chaitra Shaji, a final year resident from the Department of Internal Medicine, Government Medical College, Calicut, from India. And I'll be presenting a case report titled Brains of Stone and Spines of Steel, a case of dual ossification. Now, FAR syndrome is a rare neurodegenerative disorder that is characterized by calcification of the bilateral basal ganglia and the cerebral cortex, usually with a known underlying cause, unlike FAR's disease, which is idiopathic. Now, with a prevalence below 1 in 1 million, it typically presents in individuals aged 30 to 40 years, and hypoparathyroidism is among its most frequent etiologies. Now, ossification of the posterior longitudinal ligament involves heterotopic bond formation within the ligament, leading to neural compression, manifesting as myelopathy or radiculopathy. Now, the co-occurrence of OPLL and FAR syndrome is extremely rare. We report a case of a 40-year-old gentleman who presented to us with symptomatic OPLL and upon evaluation was found to have FAR syndrome secondary to idiopathic hypoparathyroidism. Now, coming to the case report, let me present the case of a 40-year-old gentleman with no previous comorbidities, now presenting with a complaint of weakness of both upper limbs followed by bilateral lower limbs for 3 months following a history of slip and fall. He also gives a history of difficulty moving his neck since 15 years of age, which was insidious in onset and progressive in nature. He gives history of difficulty in buttoning his shirt, combing his hair, climbing up the stairs, and wearing chappals, suggestive of both a proximal and a distal muscle weakness. He also gives a history of urinary retention and constipation during this episode. Now, since the last 8 years, he has a history of perioral numbness, which was associated with intermittent episodes of muscle cramps. He was initially treated at a local hospital and was started on some medication, following which his weakness improved, and then presented to us for further evaluation. Now, coming to the clinical examination, he was conscious oriented. The nervous system examination, the higher mental functions were within normal limits. The cranial nerves and the sensory system was also normal. Now, coming to the motor system, he had a power of 4+/5 in his left arm flexors and extensors, bilateral hip flexor, extensor, abductor and adductor, and left knee flexor and extensor. All the deep tendon reflexes were exaggerated and bilateral plantar was extensor. The range of movement of the neck was also restricted. Now, based on a history and clinical examination, we come to a provisional diagnosis of cervical myelopathy. Now, moving to the investigations, the initial investigation panel, including a complete blood count, renal function test, serum electrolytes, and liver function test was done, which was within normal limits. Now, since our history was suggestive of a cervical spine pathology, we moved ahead with the CT head and C-spine. Now, the CT head surprisingly revealed by a calcification of the bilateral basal ganglia and the cerebellar cortex, which was suggestive of FAR syndrome. And the CT spine shows an ossified band-like structure between the C2 to C4 vertebra, which was suggestive of OPL. Now, this is the MRI image, which shows compression at the level of the cervical spine C2 to C4, leading to the manifestation of cervical myelopathy. Now, we further evaluated for the etiology of FAR syndrome, and we hence checked the other metabolic parameters. We found that this patient had hypocalcemia, with his calcium levels only 6.8, with a hyperphosphatemia, with the phosphorus levels of 6.1, with the normal magnesium and vitamin D levels. Hence, we checked the parathyroid hormone level, which was found to be extremely low, suggestive of primary hypoparathyroidism. Now, this is the ECG showing a prolonged QT interval, which was secondary to the hypocalcemia. Now, we further went ahead with the evaluation of the hypoparathyroidism. This patient had no significant family history, no abnormal facies, no history of any mucocutaneous candidiasis. His cardiovascular examination was within normal limits. A pure tone audiometry was done to rule out sensory neurohearing loss, which was also normal. An echocardiogram was done to rule out any cardiac defects, which was also normal. And a USG abdomen was done to rule out any renal anomalies, which is also normal. A fasting cortisol was done to rule out autoimmune polyglandular syndrome, which also came to be within normal limits. And hence, after extensive evaluation, we concluded the etiology to be idiopathic. Hence, our final diagnosis becomes ossification of the posterior longitudinal ligament C2 to C4, FAR syndrome, idiopathic primary hypoparathyroidism. Now, coming to the management, his severe hypocalcemia was managed with both IV and oral calcium supplements, including calcitriol. And after the correction of the calcium levels, he underwent a C3, C4 decompression laminectomy and is now currently under a follow-up with a noted improvement in his symptoms. Now, to conclude, though rare, a coexisting cervical OPLL and FAR syndrome warrants our careful attention. Now, in patients with spinal ossification and neurologic symptoms, metabolic evaluation along with neuroimaging is essential to detect treatable conditions such as hypoparathyroidism. And given the associated risks of hypocalcemia, such as arrhythmias or seizures, early endocrine diagnosis and multidisciplinary management are vital. And this case highlights the importance of metabolic screening in OPLL presentations for optimized surgical planning and improved patient outcomes. This is my reference. Thank you for your patience.
So, any questions? It's an interesting case. Actually, I think we have never heard it. Actually, we see a lot of calcification of the basal ganglia.
Yeah.
At least I think it's underdiagnosed because it's quite frequent. But I mean, it's far more disease than the syndromic, of course.
Yeah, I found a similar case report. This patient actually had OPLL and was planned for surgery. And just in the preoperative period, she had seizures in the case report. Our patient, fortunately, didn't develop any seizures. Yeah.
And did you, for that patient, did you check as well the hypothyroidism or not?
For that other patient, that was not our patient.
Okay.
I told about a case report.
But
Yeah.
now, having this case, which you should do that.
Yeah, we should. Yeah, ideally, for a patient presenting with OPLL, we should check for metabolic parameters. Yeah.
But for the Paris, like, actually, I think it's underdiagnosed. Yeah, and because we see
I don't even know the prevalence in Portugal,
but
as a matter of fact, the Paris disease.
But I think every month I see at least a CT scan with.
Yeah, it's an incidental finding.
I can't say the same, but then nowadays I live in the islands, so there are differences. Probably.
Okay. So thank you very much.
Yeah.
Please, and of course, the certificate. Yes, I can help. Thank you. So I think the next chairperson is Dr. Aliana, please.
So I think we're going to start our last session. And we're going to start our first segment of this last session with talk about artificial intelligence and deep learning in revolutionizing brain tumor diagnosis and treatment, presented by SSP medical student from the University College of Dublin, Dr. Gibran Al-Houthi. Please welcome him.
So, Assalamu alaikum. Good afternoon. My name is Gibran Al-Houthi. I'm a fifth-year medical student from the University College Dublin in Ireland, and today I'll be discussing artificial intelligence and deep learning in neurosurgery, and highlighting why AI is no longer a future concept in neurosurgery, but a very real current clinical tool that's being used. So just a little bit of background. Brain tumors remain one of the most complex challenges in neurosurgery. They often involve critical regions, high morbidity mortality, and narrow margin for diagnostic and surgical error. Patient outcomes are highly dependent on early detection and diagnosis, accurate tumor classification and segmentation, as well as precise surgical planning. At the same time, modern neurosurgery is generating a vast amount of clinical data, including advanced neuroimaging, electronic health records, and genomic and molecular data. Despite these advances, clinical interpretation still relies heavily on the human eye. Clinicians are required to interpret large volumes of complex imaging, often under significant pressure. And this introduces several limitations. These include data overload, clinician fatigue, as well as variability in interpretation between clinicians. These limitations directly affect diagnostic accuracy and consistency, which creates a clear need for decision support tools. And this is where deep learning comes in. Deep learning is a subset of artificial intelligence. It uses multi-layered artificial neural networks to directly learn from data. Unlike traditional programming, models aren't given explicit rules, but rather they're given algorithms from which they can learn from and automatically identify complex patterns from large data sets. And the most common deep learning models used in neurosurgery are convolutional neural networks. So they're designed specifically for image-based data. And in neurosurgery, they're commonly used in image classification, tumor segmentation, and feature extraction. And they exist both in 2D and 3D forms, depending on which image modality you're using. Now, I'm going to go through the clinical applications of these deep learning models, just to give an idea of what's available out there for your use in your institutions. So deep learning can be integrated throughout the whole neurosurgical clinical pathway, from imaging and diagnosis all the way to surgical planning and intraoperative decisions. And its role is to be a support for clinical judgment. And we'll go through each step now. It's important to mention that these models are currently just being tested as simulations. They haven't had any clinical trials. However, their application and accuracy are undeniable. So to start with tumor detection, Early clinical problem is quickly distinguishing normal brain tissue from tumor tissue and classifying tumor type accurately and quickly. One example model that's been used for this task is Inception ResNet V2. It uses deep convolutional layers to extract image features and employs residual connections, allowing for very deep networks without losing information. That's all very tech talk, but for us clinicians, that means that it outputs a binary decision, so either it's a tumor or it's not, and then multi-class decisions as well, such as tumor subtype. And it has an accuracy of 90% in tumor detection, as well as, of course, faster assessment compared to manual interpretation. I'd also like to mention multimodal MRI integration. So there's deep learning models for multiple MRI sequences. And as we know, different MRI sequences they provide complementary information such as structural detail, edema, tumor infiltration. And DenseNet is such architecture that's been provided that preserves information flow between the layers and reuses features from earlier layers. Around 92% classification accuracy has been seen, providing improvements in tumor classification as well as preoperative planning. Then we move on to classification. So, of course, this involves identifying tumor subtype and supporting decisions around surgical approaches and adjuvant therapy. One example model used is the brain tumor classification model, or BCM-CNN used for short, and it's designed to analyze volumetric MRI data. It extracts spatial and textural features from tumor volume, and this outperforms standard CNN models. I mention this because I want to portray the fact that there's already advancements on the base models themselves. Another example is the hybrid models. There exist hybrid models that employ both a combination of the CNN and the old generation shallow networks that can extract both high and low level features. Together, they improve the classification accuracy. And another advancement is the genetic algorithms. So another challenge when tumor classifying is choosing the optimal CNN architecture. And one solution is genetic algorithm-based CNNs. Basically, it automatically selects and optimizes the CNN architecture based on the patient genome. And this AI exists, and it's very and the performance shows that 90.9 accuracy in tumor classification with a 94.2% accuracy in detection. Next, I'd like to talk about tumor segmentation briefly. So it's also been used in tumor segmentation. It's not as accurate, so 85 to 90% accuracy, and it uses volumetric structures. And what I'm most interested in is the intraoperative tumor diagnosis. So a major intraoperative challenge is that frozen section analysis is slow and resource intensive. One solution is using the stimulated Raman histology in combination with deep convolutional neural networks. This system uses label-free optic imaging to capture the tissue, and then it applies the CNN trained over 2.5 and above images. And it can provide a diagnosis under 150 seconds and with an accuracy of 94.6%. That's comparable to conventional pathology. However, it provides the real-time intraoperative decision-making and reduces operative and complication risks. And lastly, detection of brain metastases. So small metastases are easy to miss, and accurate detection is critical for future planning for stereotactic radiosurgery planning. And one of the models used is DeepMedic, and it basically does a similar thing of multi-sequence MRI data and has a sensitivity of around 88%. Finally, it can also be used for surgical route planning. So, and a model called Q-learning-based reinforcement learning models, and they basically allow for optimization of entry points, trajectories, and minimizing damage to critical structures. It supports the movement towards minimally invasive neurosurgery. And now I want to talk about the advantages of applying deep learning in neurosurgery. So the first, of course, is improved diagnostic accuracy. It outperforms traditional based systems. It has the ability to identify patterns that are not visible to the human eye, allows for early diagnosis, more accurate tumor classification, and reduced diagnostic uncertainty. It also allows for reduced inter-observer variability. So the human interpretation varies between radiologists, institutions, levels of experience, and deep learning provides a consistent output with reproducible interpretations. It has faster clinical decision-making ability, so it automates image analysis and provides near real-time outputs, like the example I mentioned of intraoperative use. It can improve surgical planning and precision, and then aids the movement towards personalized and precision medicine. And lastly, it reduces radiation exposure. So, of course, optimizing imaging protocols, maintain image quality with fewer scans, lower doses, and particularly beneficial for those patients that require long-term surveillance. And lastly, I want to talk about the limitations and the challenges. So, of course, there are ethical and legal considerations when it comes to AI: transparency, fairness, accountability, and non-maleficence, especially the accountability. Who's responsible if this AI makes an error? And then, of course, appropriate level of clinician trust is required. And at some point, informed consent is going to have to evolve to include data usage and explain the involvement of AI in patient care. Limitations in data quality. So deep learning requires large data sets, high quality, well-labeled data, and major limitations include privacy laws, restricted data sharing, and heterogeneous imaging protocols. False positives and sensitivity trade-offs. Many models prioritize sensitivity, and this has the trade-off that it increases risks of false positives and overdiagnoses. And then this recently came up in the last 2 years, which is the black box nature of AI and deep learning. Many models lack explainability. Clinicians may hesitate to trust the decisions they can't interpret. Explainable AI remains a very active area of research, and transparency is essential for clinical adoption and medical legal safety. And then, of course, integration into clinical workflow. So without integration, proper and effective integration, even accurate models will go unused. AI must integrate in existing radiology systems, surgical workflow, and the major barriers to this are infrastructure, cost, and especially training. Now, just to run through a few of the clinical impacts that this may have, AI has been, will always be an augmentation, not a replacement. AI will not replace neurosurgeons. The best outcomes occur when AI supports clinical judgment. There is a simple fact that human plus AI outperforms either alone. Then you have real-time intraoperative AI, like I mentioned, brain-computer interfaces that have already been used in restorative neurosurgery, like neurorehabilitation and functional restoration. You have AI-guided robotic surgery, personalized neurosurgery, and then, of course, the effect on MDTs. In the future, in our future, MDTs are going to look very different. We're going to have to require a much wider variety of disciplines within our MDT meetings. And then a few key messages to take home is that deep learning is no longer experimental, but a very real clinical tool that can be used currently in this day. AI matches and exceeds human performance in selected diagnostic tasks. The real challenge is integration and trust, not algorithmic accuracy. And the future of neurosurgery is human intelligence amplified by AI. Just want to mention my contributors here for the paper. And then if this interested any of you, as a continuation of this paper, me and the team went on to use NVIDIA's MONAI, its Medical Open Network for Artificial Intelligence. It basically provides a template for building this machine learning programs. And it's very simple to go through and allows for the layperson such as us that doesn't really have a background in software engineering to kind of create their own, to decide what parameters you want to use, to decide what imaging you want to train the AI in. And then, of course, you can assess its accuracy compared to conventional or newer AI models. And thank you. Thank you.
Well done, absolutely great talk. And in my opinion, I really think that ignoring AI is a disservice to humanity because of how much lives it can save. And at the same time, a bigger disservice would be misusing AI. So the best way to do it is through augmentation. And I think, as I've mentioned before, that augmenting with AI puts the standard much higher.
Yeah.
The clinician has to learn much more to meet that very much higher standard, better healthcare, to provide the better healthcare for the patient. So very well done.
Thank you.
Are there any questions? I know that ask any questions or comments.
Hi, I would like to ask about AI hallucinations. I do use AI in clinical practice, and AI hallucination is not uncommon, which it produces, information that sounds very reliable and trustable. But in fact, if you lack the clinical experience and judgment, you easily get caught in the over pathologizing or maybe the wrong diagnosis. So what are some frameworks or safeguards that you put in to prevent the AI hallucination?
So it's actually a new term for me. I've never heard of AI hallucinations. But in terms of the safeguarding of AI, so it's not overvalued or over depended on, is the same fact that it has to be used as an augmentation. It can never replace final judgment, clinical judgment. Regardless, there has to be a team of clinicians there that use it as an aid, as a guide, as potentially even facilitating or optimizing tasks that may require resource-intense clinicians or even other healthcare professionals. The fact is that clinical judgment has to remain with the clinicians at the end of the day.
Oh.
I think last thing I'd like to add, just because in my country, the cancer centers we had, we actually have like a research department entirely for AI.
Yeah.
And then it's been newly done. And recently what they did is they incorporated, AI into post-note writing. So it would flag mistakes and that kind of stuff. But we haven't got yet to the diagnosis and that. As you've mentioned, the currency or the most important thing, the token, is the data sets.
Yeah.
The data sets are there and the algorithm can be made. I think looking forward, that's probably soon to come. It's guaranteed to come at some point. So we're going to be looking forward to it. And thank you for the talk.
No worries. Thank you.
So up next, on our next session, we're going to have a talk about KI1 malformations. It's going to be presented by Dr. Muad Bakr, a fellow engineer in neurosurgery at Queen's Hospital in Essex.
Thank you very much. Where is it? Close here. Probably get the notes. You want to get notes? Yes, go. Let's see. All right. Good afternoon, everyone. My name is Moaz. I'm Neurosurgery Junior Clinical Fellow based in the UK. It's a pleasure here to present our recent study about KRI1 malformation. And here's a quick overview about KRI malformation. It's a structural abnormality involving downward displacement of the cerebellar tonsils through the foramen magnum, leading to a wide range of neurological symptoms and radiological findings. And this making KRI malformation one of the most debated conditions in neurosurgery, not just because we sometimes fail to recognize it, but also because deciding who truly benefits from surgery is still inconsistent between neurosurgical centers. Today, I would like to share our experience in addressing this challenge and introduce a simple and objective KRI1 malformation severity classification system to support surgical decision-making. And the main aim of the study was to explore the link between the clinical symptoms and the radiological findings, as well as to explore the link, to explore the factors which are associated with surgical interventions. And finally, most importantly, to introduce a new severity classification system that can improve the preoperative decision-making and post-operative outcomes. So to address this aim, we conducted a retrospective 12-month study at a tertiary neurosurgical center with a dedicated KRI and syringomyelia services. We included adult patients with confirmed KRO malformation, and our data was included demographics, clinical symptoms, image findings, and surgical outcomes. In total, we analyzed 69 patients with a mean age of 36 years old and a female predominance. And based on these findings, the results showed around 43% of patients were presented with classical Chiari symptoms, and the majority of them had tonsillar descent of more than 10 millimeter below the foramen magnum. And when we looked at the most factors that associated with surgical interventions, 2 factors clearly stood out: the classical Chiari symptoms and tonsillar descent of more than 10 millimeters below the foramen magnum. And both of these factors showed statistically significant association with surgical interventions in form of foramen magnum decompression with a p-values less than 0.01. And based on these findings, then we developed this Chiari-1 malformation severity classification system to support the surgical decision-making. It's basically designed to be simple, objective, and easy to use in our daily clinical practice by assigning points based on the 2 factors that we mentioned earlier, the tonsillar descent and the clinical symptoms. And each of these components each of these parameters contributes to the total grade, allowing the clinicians to have a clear and objective way to assess the disease severity, rather than just relying on subjective judgment alone. So the clinical symptoms, based on whether the symptoms are mild, moderate, or severe. Severe has the most marks, and the tonsillar descent, whether it's below 5 or less than below 5 or more than 5 millimeter below the foramen magnum. And this table here shows how the final score guides our management options. So the lower scores from 0 to 2, 0, 1, 2, correspond to mild or moderate disease, where conservative management or observation are highly advisable. And the higher scores, 3 or more, correspond to moderate to severe disease, where surgical interventions should be strongly considered. And this table here is important, especially when discussing the treatment options with the patients, while counseling with the patients. And when we tested this proposed classification system, it demonstrated excellent diagnostic performance with the area under the curve 0.97%, which is indicating an outstanding accuracy to identify patients who require surgery. And we used a cutoff of 3 points or more. And when we used this cutoff, it actually achieved 100% sensitivity and nearly 90% specificity with a perfect negative predictive value. So in practical terms, this system means it's highly effective in identifying patients who should not be missed for surgical decompression, while also helping us to avoid unnecessary operations. In conclusion, the Chiari-1 malformation severity classification system is a clear, objective, and easy to use tool that shows strong potential in identifying patients who will benefit from surgery. This scoring system does not replace our clinical judgment. Instead, it supports our preoperative decision-making and postoperative outcomes by offering a structured approach to the management options, improved consistency between clinicians, and more importantly, greater standardization of our clinical practice across neurosurgical centers. Although this study was a single center retrospective study, but the findings are highly promising, and currently a multicentral prospective study is already planned to be conducted to confirm this classification reliability and hopefully to make further refinements within our neurosurgical field. Thank you very much.
Well done. Does anyone have any questions or comments?
I think this is an international issue because from time to time we have a patient with a borderline malformation, and the patient has already read everything about surgery and symptoms and everything. So, do you have this problem when the patient comes to your appointment? He or she already tells you all the possible symptoms that the books say, and of course you are going to perform a neurological examination. It's obvious. You see the patient walking. I used to say the appointment starts when the patient enters the room.
The room, exactly.
And you see the patient walking.
Yeah.
And then the patient almost tries to convince you that you should operate on him because he has that terrible thing called Arnold Chiari malformation. And that's a stigma. And you have to go around to explain to the patient that it's not a death sentence, as the patient thinks. And there are many grades, and you have to have a handbook for the patient. It happens with everyone, or it's just
completely correct. I agree with you. Yeah, it actually happens with us all the time. We have like a Chiari malformation dedicated clinics, weekly clinics. So as you said, all the patients have broader knowledge about the symptoms and all the signs of Chiari malformation and all the possible management options. So it's quite difficult to convince the patient that at the moment he doesn't need surgery or he needs it at the moment. But this classification system, I believe, will structure this counseling and give another options for you as a clinician or as a clinician to discuss with the patient and convince them further.
Yeah,
because you'll have an objective tool, just not just subjective symptoms.
Sometimes I even tell them I love to operate on people, That's what I love to do, but I'm not going to operate on you because you don't need it.
You don't need it, exactly, yeah.
And many appointments to reassure the patient that everything is under control, because if he doesn't see me, especially the people that are more prone to anxiety, anything they feel, they think, oh, it's this thing.
Yeah,
Patients that get to you already with the late stage symptoms, like with the symptoms of syringomyelia or hydrocephalus, and they just don't get to me at the point where you have to perform surgery. And then you get, and especially females, not middle-aged, younger, the 30s, 40s, that every day and then they focus on the symptom and they just need it's very difficult sometimes to manage, and then they don't get better sometimes with the surgery. And you have to tell them that it takes time because
I totally agree with you. The counseling of the patients with Chiari symptoms is very, very difficult, very challenging, and I believe there is two classification system for cardiac malformation at the moment, which is the Chicago cardiac malformation, but this one is a post-operative classification system, but it does not support the counseling before pre-operatively. And the other score does not support the counseling itself, it support the post-operative outcomes as well. So this classification system, I believe, will improve the counseling of the patients with objective tools and but also in the UK there is a long waiting list for the patients to have a decompression. So it's not their choice. It's the same.
We're having serious trouble with our NHS, our version.
Exactly, yeah.
Serious.
Yeah,
serious
so the waiting list is up to 2 years to have a decompression foramen magnum. So it's not mainly the patient choice, it's a preferences from the patient, but always you can convince them that it doesn't need the surgery at the moment.
Years of the symptoms starting, so that when we operate, you know, the patient.
Sometimes it's early and sometimes it's too late, exactly. But based on this table, I believe will give us an exact time when to operate and when to avoid the unnecessary operations.
I do actually,
Thank
when
you.
I went to the UK as well, one of the things I was very, very surprised about that the cardiac malformation patients, cardiac malformations, they came in and they knew everything. Like their MRI, their everything. And
Correct.
almost, as you said, they tell you
Yeah.
the management plan
Yeah,
that
exactly.
they want.
Yeah, true.
Yeah.
Yeah.
So do you think that with such an objective tool that would be generalized and validate, do you think this would, I'll say this would help the clinician. Do you think this would also calm the patient down? You could tell them you're grade 0, you're grade 1. We can hope, I guess.
Try.
Yeah.
Could try and see what happens.
They see their grade 1 and 0, they might.
That's right.
Yeah, totally. But still in the early process, we need to do a multi-central study to confirm and to do further validation of
Validate
the system. Exactly, yeah. So hopefully, thank you very much. Thank you. Thank you very much. Thank you all.
On our next segment is about craniosacral junction mangioplasma, looking at apnoid. It's going to be presented by Dr. Ernest Jesus, once more joining us.
Yes. Is it
for an
possible
amazing
because I made just a
presentation.
little change if so yeah, it's just yes. So hopefully okay. So okay. Yes.
Perfect.
Perfect. So I hope you're ready for round 2. So this is a different case. I think it's interesting as well because literally is a case about an atypical presentation of a mangiblastoma that leads to misdiagnosis and actually makes the life of neurosurgeons very difficult as well during the surgery. So just a quick review, hemangioblastomas, as you know, are benign vascular tumors. They are roughly 1 to 2.5% of all intracranial neoplasms. They have as well a predilection for a posterior fossa, especially cerebellum, and usually the symptoms are QD edema or pseudocyst growing or sometimes hemorrhage, and 20% are also associated with von Hippel-Lindau syndrome. They can present usually as cystic lesions with a mural nodule or solid lesions. Okay, and sometimes a typical imaging can as I said, lead to misdiagnosis and who makes us think about other non-neoplastic cystic lesions, like in this case, arachnoid cyst, or other also benign tumors. So this is the case of a 32-year-old woman that presented with a 2-month history of headache that was worse during the night, also irradiated to the cervical spine, and she had complained of some vertigo. And apart from some nystagmus and left side dysmetria, she didn't have any other neurological symptoms. As you can see here, the CT scan demonstrates a well-defined cystic lesion. So in the left cerebellar hemisphere, extending through the foramen magnum until C2 vertebra, compressing the brainstem and also the cerebellar structures. Then, of course, the CT scan is not enough, so we performed as well MRI scan, and this is T1 contrast sequences, and as you can see, there is no at least nodule or mural nodule and enhancement with contrast. There is no diffusion restriction or vascular flow voids that are also very typical for hemangioblastomas. And the MRI was reported, and also after discussion in our department, we all thought that it could be an arachnoid cyst. And also the hemangioblastomas, usually they don't cross and or extend to the spine. They can also occur in the spine, but they usually don't cross areas. So, of course, when do we choose to operate these patients with hemangioblastomas or the other benign tumors of the posterior fossa, or also non-neoplastic lesions? Usually when we need histology, when these lesions start getting symptomatic, when they are asymptomatic but they show growing or progression in imaging, and of course when they present with other symptoms such as obstructive hydrocephalus. So, given that this patient was becoming symptomatic, we decided, and she was young, and the cystic lesion was actually compressing some important structures, we decided to operate on her. We did a occipital craniotomy, and then we did microsurgical excision of the lesion. This is also 2 types of incisions you can do. We chose a median line incision. And then, to our surprise, we are thinking we are going to find an arachnoid cyst and we are going to fenestrate. And we found this lesion. As you can see, this is a typical image for hemangioblastoma. We have a mural nodule, okay? We have a cystic component, and then a draining vein, can be an invasive, but usually is a vein. Okay, so we had to change completely our approach to the surgery. Usually, when we perform hemangioblastoma surgery, we should do always a wide enough exposure, okay? Because they are vascular, they can bleed. In this case, we actually did a very good size craniotomy, so we are lucky. And then, of course, when these lesions are cystic, we can also drain the cyst, get some working space, and we should identify the mural nodule and the vessels that cross it. If we occlude the feeding vessels, we should always prefer to occlude first the arteries before the draining veins, otherwise it can bleed. And we should dissect carefully, and this was exactly what we did, the tumor, and sometimes we can also use, in a careful way, some coagulation without damaging, of course, healthy tissue around. Then, of course, we have to do very meticulous hemostasis. Usually, it stops with some gentle packing and oozing. especially when we removed the full lesion. And that's exactly what we did. But intra-op, we were expecting something else, and we had to change completely the approach. And also it took longer. So I was also with a consultant that was very experienced. So after all, all went well, but it could be sometimes a bit more unfortunate. This is the postoperative CT scan. As you can see, we removed the whole lesion, and then she did a follow-up MRI as well. And now I think I don't know if they all work, but as you can see, it's gone. So this is just some residue liquid as well in the surgical site, and there is no contrast enhancement. Sometimes in hemangioblastomas you shouldn't, if it doesn't enhance with contrast, you shouldn't remove the walls as well. But as soon as we ruptured the cyst, it kind of shrunk. The histopathology came back as hemangioblastomas. We are already sure about it intraoperatively. And of course, it usually presents as a high vascular tumor with stromal cells. Okay. And we also tested positive for alpha inhibin. So this case was a little bit different because it's a typical presentation, led to the misdiagnosis initially, and it was a completely different presentation of hemangioblastoma. Had no imaging features of the tumor, and therefore the diagnosis was dependent, especially on histopathology confirmation. This is just a quick table showing how atypical was this case. So, like I mentioned before, hemangioblastoma usually affects the cerebellum, brainstem, or spinal cord. This one extended was cerebellomedular and extended also to the spinal canal. Again, there was no mural nodule seen in CT, MRI. There was no enhancement as well. And again, the only thing we didn't do in our MRI study was to check perfusion. Maybe we could have some increased perfusion, but again, I doubt it. So again, just to conclude, in the case of cystic posterior fossa masses or lesions that extend across the foramen magnum, we actually should think about the hemangioblastoma as a differential diagnosis, even in the absence of the classic features. And we should always rely on multimodal imaging and histopathologic assessment for an accurate diagnosis and optimal, of course, surgical management. So these are some of the references as well. And this is the Coimbra Hospital. So it's just a simple case, but I think it's interesting for at least for the neurosurgical side.
So you had a big craniotomy, but you were not prepared to move the arch, C1 arch?
C1, yeah, we didn't. So we did actually a good suboccipital craniotomy. We didn't remove the arch because we were expecting it to be an arachnoid cyst. So, but like they say, in Portugal we say big surgeons, big incisions, and big craniotomy. So we went for it, okay? But it was actually challenging, and we were lucky as well. And thank you for actually mentioning that, because imagine we were expecting a arachnoid cyst, and thankfully when we opened the cystic lesion, it kind of collapsed and shrunk, because otherwise we'd have again to maybe extend even further. We had also removed C2 posterior arch, so it would be a big trouble. So in this case, was lucky that the cystic component was the one.
Brought the nodule
Exactly.
into sight.
But and actually we saw, and again, as soon as we opened, we encountered the mural nodule. And again, if we haven't seen it, and if it was maybe more anteriorly, we would have left tumor there. And so maybe the patient had to undergo another surgery. So was, of course, annoying, and was a misfortune to not have a good image, diagnosis before the surgery, or think that it could be hemangioblastoma, but actually the tumor itself, behaved well and helped us, but it could be a challenge. Yes, yes, I agree.
I have another question, just like from your knowledge and your experience, if you encountered a similar case like this in the future where you find a similar thing that looks like an diagnosis, would you do anything different?
Depends. So what I would do different in this case, I would consider that could be a hemangioblastoma, even though all the features were not present, could be an atypical presentation. So it kind of broadened my differential diagnosis. I would probably ask for a perfusion sequence, and I would be prepared myself to, again, in the case to be a different thing of arachnoid cyst, I would do the big craniotomy, and also maybe removal of the arch of C1, and consider it definitely.
That very low cerebral
So
vision.
it kind of is this case is a eye opener, I think. It's a different presentation, a typical, we never seen it. We have quite senior consultants, and including the one I was now. I don't know if Dr. Annabelle knows Dr. George Gonçalves. He's quite, and he was like, no, it cannot be hemangioblastoma. It doesn't extend to the. So he was very, and we were like, okay, baby. Again, hemangioblastomas, they have flow voids, because and it had nothing, so it kind of and then it was a beautiful mural nodule with a cyst, and actually our microscope was broken at the time, so then went for repair and we got a new one as well, but we couldn't film it, so we actually took pictures. We managed to take pictures, so and
we are operating with the ENT microscope.
Okay, so we are better. I won't complain then.
Thank you.
No, thank you.
Well done. Thank you.
Okay. Yes, let's go for the picture, and thank you. But it's not this case. Okay. Thank you. That's okay. Just side.
Yes, okay.
Thank you.
And finally, for the last session, we have a case series patients treated with microvascular decompression, and it's going to be presented by Dr. Ahmed Jafira.
Actually, it's a typo error. My paper that I'm going to present is about comparative clinical outcomes of transsphenoidal and transcranial surgery for cellular suprasellar masses. So this is a 6 years single institution retrospective study. So before anything else, I would like to grab this opportunity to thank UCG for inviting me here. And by the way, I'm Ahmed Jeffrey Disangkupan. I just graduated my neurosurgery residency last December at Vicente Soto Memorial Medical Center in Cebu, Philippines. So we choose this topic because coming from a limited resource setting and a third world country, so we are trying to find what policy that is more efficient for us to do. So just an background of the study. So cellular and supracellular masses, predominantly pituitary adenoma and your craniopharyngiomas, represent one of the most common indications for neurosurgical intervention at a tertiary referral centers. These lesions frequently present with visual impairment, headache, hormonal dysfunction due to mass effect on the optic chiasm, pituitary stalk, and hypothalamus. So surgical resection remains the cornerstone of treatment with the primary goals of relieving neurologic compromise, preserving or restoring vision, and achieving long-term tumor control while minimizing morbidity. So, as we all know, transsphenoidal approach, they are now predominantly performed endoscopically, and it has evolved as the standard of care for the vast majority of cellular lesions worldwide. They offer direct midline access, reduced brain retraction, shorter hospital stays, and lower complication rates compared to the traditional transcranial routes. On the other hand, as to the transcranial approach, they generally reserve for tumors with significant lateral, anterior or superior extension, unreachable via the transsphenoidal corridor, or for complex craniopharyngiomas with these adhesions to critical neurovascular structures. So for the general objectives in this study, we compared the clinical profiles of perioperative complications, visual outcomes, short-term clinical results of the transsphenoidal approach. So some of the specific objectives that we had. So for our study population, all consecutive patients aged 18 years and above who underwent surgical management for cellular and supracellular masses during the study were included. Pediatric patients below 18 years that managed conservatively, and those with incomplete records were excluded. So we only have a total of 141 adult patients that met the inclusion criteria and comprised the final study population. So for the inclusion criteria, adult patients aged 18 years and above who underwent surgical management, either transsphenoidal or transcranial approach, for histologically and radiologically confirmed cellular and supracellular masses. So for the exclusion, patients younger than 18 years, those managed conservatively without surgery, those with incomplete medical records, lacking operative notes or neuroimaging, those who expired before surgery, then those who refused surgery or were discharged against medical advice prior to operation, they were all excluded. So some of the operational definitions of the study variables. So for the scope and limitation of our study, so the study encompassed all consecutive adult patients underwent management of cellular and supracellular masses. So again, it is a 6-year period providing a comprehensive experience during the full transition to endoscopic transsphenoidal surgery as the dominant approach. It focused on short-term clinical outcomes, perioperative mortality, complications, visual recovery at discharge, and crude recurrence regrowth when documented, thereby establishing reliable local benchmarks for safety and efficacy in a high-volume tertiary setting. However, due to its retrospective design, introduced inherent limitations, including absence of standardized long-term follow-up protocols, resulting in incomplete data on endocrine function, quality of life, and time to event recurrence analysis. So for the results, so we have a total of 152 patients we excluded the pediatric patients, so a total of 11. Then the primary pathology, we have in cases of primary adenoma, we have a total of 117 with the non-functioning of 97, prolactinoma of 9, growth hormone secreting of 3, and the recurrent of the previous of 12. And then for craniopharyngioma, we only have 17. So there are calcified, cystic, and often giant. So for the decision on surgical approach, so for the endoscopic transsphenoidal surgery, we have 109 patients, 104 adenomas, 4 craniopharyngiomas, and 1 meningioma. For the craniotomy, either terional, frontotemporal, or orbidozygomatic approach, we have 9 adenomas and 11 craniopharyngioma, so a total of 20. So of all the operated, improved, we have 105. We have 3 perioperative death in the transsphenoidal approach. We have a reoperation of CSF leak, about 6 patients. And then for the follow-up, we have a total of 131. And then for the pituitary adenoma recurrence, out of the 109 transsphenoidal surgeries, we have 10. And for the craniopharyngoma, we have 4. So for these are the demographic and the clinical characteristics. So the median age was 47, 48.1. Then with the male preponderance. So for the pit ad, again, we have 117. The non-functioning adenoma, we have a total of 97. Prolactinoma, 9. Growth hormone secreting, 3. Recurrent adenoma of 12. And then meningioma, 2. Craniopharyngoma, 17. Others are 5. We included here are some Rutgers cleft mouth cyst. So in the presenting symptoms, usually about visual disturbance, the most common, followed by your headache. So for the comorbidities that we have identified, so we have hypertension as the most common, followed 58%, followed by your diabetes mellitus of 22. So for the mean and range size of the tumor, we have about 3.4 cm, and the giant or greater than 4 cm of about 25. So for the perioperative mortality, both transsphenoidal and your transcranial, we have 3 each. So for the surgical approach, as I mentioned earlier, we have male preponderance, and then pit ad as the main histopathologic diagnosis. So for the tumor size, we have 14 giant. For the comorbidities, again, usually both in endoscopic and the open craniotomy is hypertension, which is most common. And then presenting symptoms of visual disturbance. So for the univariate comparison of outcomes for mortality visual improvement between transsphenoidal and craniotomy. So perioperative mortality, again, we have 3 in both sides. Overall adverse outcome, we included there the death, the discharge against medical advice or not operated. Both have 4. And then for gross total or near total resection, in the transsphenoidal, we have 91 out of 104. And for craniotomy, we have 7 out of 9. Major complications, CSF leak, so 6. And then for the length of stay, usually we have, in the transsphenoidal approach, it's usually 3 to 7 days. And then for craniotomy, 10 to 21 days. For the visual improvement, usually the bitemporal hemianopsia. So for the endoscopic transsphenoidal, we have 78 out of 82. And then for craniotomy, 12 out of 16. And then severe visual loss pre-op or legally blind. 22 out of 109 for the endoscopic transsphenoidal approach, and for the craniotomy, 8 out of 20. So in the conclusion of our study, so the 6-year retrospective study of 141 adult patients at Vicente Soto Memorial Medical Center confirms that endoscopic transsphenoidal surgery has become the dominant and significantly safer approach for the management of cellular and supracellular masses in a high-volume public tertiary hospital in the Philippines, with a 77.3% of cases performed endoscopically. It achieved a perioperative mortality of only 2.8%, visual improvement in 95% of patients with preoperative deficits, and major complication rates comparable to international benchmarks, despite a high burden of late-presenting giant tumors and medical comorbidities. In contrast, transcranial surgery, reserved primarily for craniopharyngiomas and complex giant adenomas, was independently associated with nearly twofold increase in mortality risk and lower rates of visual recovery. So, ultimately, this study demonstrates excellence in pituitary and supracellular surgery achievable in public hospital in the Philippines through the widespread adoption of modern endoscopic techniques, thereby improving patient safety, functional preservation, and equitable access to advanced neurosurgical care. So, we have, regarding our recommendation, based on this 6-year study, so for the majority of the cellular supracellular masses, the following evidence, recommendation, are proposed for clinical practice, training, and policy in resource-limited settings like public tertiary hospitals in the Philippines. So this align with international guidelines, emphasizing minimally invasive techniques while acknowledging the need for selective open surgery in complex cases. So here are recommendations. For clinical practice recommendations, prioritize endoscopic transsphenoidal surgery as first line for pituitary adenomas. Reserve transcranial approach for selected complex lesions. And then enhance pre-operative optimization. Another, for the training and institutional recommendation, expand endoscopic training programs, invest in basic infrastructure, like the use of because some of our hospitals there have no endoscopic towers. And then lastly, for policy and research recommendation, so future research direction for low and middle income country, prospective multi-center studies in the Philippines should track long-term endocrine function, quality of life metrics, and cost effectiveness, incorporating adjuvant radiotherapy protocols for subtotal craniopharyngioma resections to address our 23.5 recurrence rate. Randomized trials on stage versus single-stage approaches for giant adenomas would further refine indications in research-limited settings. Implementing these recommendations will optimize patient outcomes, reduce healthcare costs, and promote equitable neurosurgical access. So building our recommendation has a demonstrated success in achieving international benchmarks despite constraints. Thank you.
Then when I ask any questions or comment?
I wish you a very successful career. You're getting started now, as I understand. I saw numbers, dimensions that wow, big tumors.
Yeah.
Some of them. And in the end, I'm only doubtful about the radiotherapy protocols for lesion situated in this specific area. Do you have gamma knife?
Yeah. We only have one gamma knife in Cardinal Santos in Manila.
Yeah, because if so, it would be more, appropriate to think of radio surgery instead of radiotherapy, because that's too, in my opinion, too generalistic. Because the main problem about craniopharyngioma should be the location and proximity to the chiasma, and it's something you should not irradiate. So if really needed, if not possible, to go there again. Because some surgeons opt for that modality.
Yeah.
Go the first time, then let it, I mean, everything is hot, let it get cold, because it's a big tumor sometimes when it's discovered. Go there a second time before thinking of irradiating, because of danger of optic nerve. That's the main concern. That's the only thing that I thought about when I saw the general radiotherapy suggestion.
General faculty, are there any comments or questions? Just present now. Now for the closing remarks. Giving out more certificates for participation in this conference. Certification